Our next talk is by Dr. Ranjit John. For those of you that work in tertiary care centers, you're aware that we are presented with patients with failing ventricles throughout the timeline and throughout the continuum of severity. And you can't hear anything? Hey guys, you sure? Sounds like either I'm hearing an echo in my head or the mic is indeed on. At any rate, feathering all these technologies together and figuring out when, where, and how to use them is very complicated and requires a protocol-based approach. And Dr. John is going to illuminate us on this particular topic, and I look forward to his talk.
Thank you, Mike. Is the mic working now? So my task over the next 20-25 minutes is to talk about algorithms for support of the failing heart. And a lot of my talk is going to be based on what Dr. Levy already talked about, the use of pharmacological support of heart failure. My disclosures include research grant from Thoratec and Heartware. We all know there's a high mortality for patients with acute cardiogenic shock that's refractory to inotropes, intra-aortic balloon pump, and revascularization strategies. And the use of permanent VADs in some of these patients has been an option, but difficulties with doing permanent VADs in this very sick group of patients is fraught with difficulties. It's major surgery. It's an expensive option with often futile results. And many of these very ill patients with the failing heart require biventricular support. And in some of these groups of patients, as listed on this slide, there is a hesitancy to implant permanent or sometimes even any kind of mechanical circulatory support for obvious reasons, especially patients with unclear neurological status, who have had CPR or prolonged hypertension, patients who are very ill despite the balloon pump, pressors, their blood pressure in the 40s, 50s, extremely tachycardic, those with end organ failure, acute renal failure, those who have received recent doses of Plavix or 2B3A inhibitors who are at extremely high risk of bleeding and coagulopathy. And some of these patients, and we have many examples in my talk, are often left to die at many institutions, even ones that have access to permanent and temporary VAD support. And clearly there is a need to develop an inexpensive and a quick way to allow these patients to live as a bridge to decision. These are the etiologies of commonly seen acute cardiogenic shock, the overwhelming majority being acute myocardial infarction with a distant second, the rest of the mentioned etiologies. Now, this shock trial, done almost a decade ago, shows how dismal the results are, and many of these patients are not even the sickest of the sick. Patients with acute cardiogenic shock secondary to an anterior myocardial infarction who presented at several medical centers were randomized into two groups. One group went for revascularization, either a CABG or a PCI, and the other group went to the ICU, balloon pump, Swan-Ganz, inotropes. Irrespective of what was done to these patients, over half of these patients died at the end of 30 days. And at that time, and even now, the modalities used for these patients include thrombolytics or stenting, inotropes, a balloon pump, and then CABG and revascularization if indicated by anatomy. And centrifugal pumps have been used like the Biomedicus pump for almost 30, 40 years, ever since the institution of cardiopulmonary bypass for heart surgery. And there have been scattered reports over the last 3 decades, mostly for failure to wean from cardiopulmonary bypass after surgical operations on the heart, some indications for short-term support for acute myocarditis, but the bearings and the very limited durability prevented any form of long-term support. And the central cannulation techniques always required a patient who was intubated and sedated and anesthetized. And the survival rate, though encouraging at that time, was rather poor. Now, before getting into the algorithms and the various examples, I divided the failing heart into two kinds of scenarios. One is the acute setting, and two groups there. One is in the operating room in the post-cardiotomy state, and the second group was outside the OR patients crashing from a failing heart acutely, either in the cath lab, which is usually the Friday night call for many of us heart surgeons, or the emergency room and the ICU. The chronic group is probably just accounts for about 2% of my talk, and that's a lot more established over the last three decades, and especially with the overwhelming evidence from the second and third generation continuous flow devices over the last few years. And that scenario is the chronic heart failure clinic patient who's New York Heart Association 3B4A4, or the chronic heart failure who's inotrope dependent. Again, the chronic group is much well-established therapies, and I will not dwell too much on that. So, this is the kind of patient that we see, once a year or twice a year. Different scenarios, but kind of similar outcome. A young man arrested on a basketball court during a game. Thanks to the widespread availability of defibrillators, he underwent resuscitation there. They got a rhythm, but another cardiac arrest during transfer. And on arrival to the hospital ICU, very hypotensive, tachycardic, his extremities are cold and mottled, and it's about 45 minutes to an hour since he first arrested. He's on wide open lever-fed and epinephrine. A quick echo shows, a barely moving heart. Again, this is the most dramatic presentation of the acute failing heart, but these are some of the treatment options that I listed. And one is to put a balloon pump and say, let's continue with wide open drips. Take the patient to the OR and either put some sort of temporary mechanical support, and I've listed the various pumps, or put in a permanent device, L or RVAD or BiVAD, and with the availability of percutaneous devices, take the patient to the cath lab and have the interventional cardiologist do something, or say, this is too far gone, he's had 30 minutes of CPR, and let the patient expire. And we may get various numbers if I did a show of hands in this audience. I think there clearly is an increased role for temporary mechanical support for the failing heart, but there are many questions which unfortunately have increased in recent years with the increase in number of devices available, such as what is the ideal device, which one should my hospital have, or should I have a couple of them? Does this patient need single or biventricular support? When should I do it? Should I put it right away, or should I wait for a few hours to see if things get worse or better? Who should be doing it? Should it be done in the cath lab, ICU, bedside, the operating room? That's a dilemma because many of these patients may not make the trip to the operating room. And if we do put something in, how long should we continue them for? And, what do I do once I put it in? Should I move the patient to a tertiary center for permanent support, or should I watch him for a few weeks at my institution and be up all night for several days? And again, a list of the various options available, just for completeness of this talk, from traditional balloon pump to ECMO. Temporary VADs include surgical devices, and I listed a bunch of them. And the two percutaneous devices is the impeller, which comes in a couple of sizes, and the tandem heart. So moving on to treatment strategies, and I've got some case examples for each. So the first is the post-cardiotomy state. Again, before we get to the VAD, if a patient is having elective high-risk surgery, a couple of things include, be prepared for a possible VAD in terms of insurance, discussing it with the family and with the patient and the family. Sometimes a day or two of pre-op optimization with a balloon pump and Swan-Ganz and directed pressure inotropic diuretic therapy may be appropriate, and also very important to have an early discussion with anesthesia that this patient is high risk and may need more than the usual inotropes. Once there are signs that this patient is failing to wean from cardiopulmonary bypass, a couple of the basics is optimized conditions, temperature, electrolytes, sinus rhythm, AV pacing is essential. Watch the right heart and treat right ventricular dysfunction. Transesophageal echo, if not already mandated in most institutions or being used for routine surgery, is obviously mandatory in these patients who are undergoing high-risk surgery, and various techniques to assess coronary graft patency and flows if indeed this is a patient who had a CABG. Once there are clear signs of If there are clearly signs of ventricular failure, we heard from Dr. Levy about the various use of inotropes and vasoconstrictors that I'm not going to elaborate upon. Nitric oxide and Flolan for patients having RV problems and poor oxygenation. Clearly, in some of these high-risk patients, leaving the chest open for a day, 2 or 3 is a well-established strategy to be used. And I think the most important thing is, after 1 or 2 well-attempted weans of cardiopulmonary bypass which fails, I think it's important to proceed with placement of a temporary VAD in these patients rather than wait and try several attempts or even try to flog the heart with massive doses of pressors and try to make a run for the ICU, because inevitably you're going to be back or risk a cardiac arrest on transfer or in the ICU when options are even more limited. A couple of examples. Again, I have 3 case scenarios for post-cardiotomy shock, and while all of these are success stories, I can assure you, and you probably don't need any assurance on that, that for every success, there are probably 1, 2, or 3 failures also. So this woman underwent an aortic dissection repair, which involved the right coronary artery. She had a classical Bentall repair with a vein graft placed to the right coronary artery, and coming off bypass, there was severe RV failure. The surgeons placed a biomedicus RVAD with right atrial and pulmonary artery cannulation. After transfer to us, we switched her to a Centromag RVAD because of the prolonged durability of the Centromag device. We had a couple of attempts at weaning over a period of 1 to 3 weeks, and when her right side was still failing and required the support, we then switched her to a Thortec PVAD or an IVAD, and with that, her right ventricle recovered after 4 months, and she was explanted. This young man underwent a coronary artery bypass with coronary artery disease, underwent stenting of the LAD and the diagonal artery, didn't take his Plavix, and presented back with a cardiac arrest because of closure of the LAD stent. They attempted restenting in the cath lab but could not do so. The surgeons did a coronary artery bypass ×2, and again, because of the massive MI, the patient could not be weaned from cardiopulmonary bypass. Again, this patient underwent placement of a biomedicus BiVAD, and oxygenator was added on to the right side because of poor oxygenation. And again, you can see how sick these patients are, which they are always. This patient was transferred, was switched out to a Centromag device again because of the prolonged durability of that device. Over a period of 1 to 2 weeks, the patient woke up, kidneys recovered, patient was able to be extubated, the right side recovered, and this patient was switched to a permanent HeartMate 2 device and discharged a couple of weeks later. Again, a use in this patient where they couldn't wean off bypass and used a percutaneous device, again at an outside hospital. An older woman underwent, with low EF, underwent coronary artery bypass grafting and a mitral valve repair for low EF and severe MR. Couldn't wean off. The surgeon placed an impeller 2.5, which worked in this patient because she was a woman with low body surface area, low BMI, transferred with an impeller that couldn't be weaned over a week, and that she was switched to a HeartMate 2 several days later. Moving on to a crash to an acute failing heart outside the OR, and this is an example of a patient who had a failing heart in the cath lab. Again, a gentleman presented with an acute coronary artery syndrome, hypertensive in the cath lab despite an intra-aortic balloon pump. They placed an impeller because of impending cardiac arrest. While on support with the impeller, had a left main stenting, which was successful. However, the patient remained on impeller support over the next few days because of a low EF secondary to a massive myocardial wall infarction. The impeller couldn't be weaned, and we bridged this patient to a permanent device on day 2 or 3. Now, obviously in the OR, you don't have to take the patient to the OR, but for the acutely failing heart, once you make the decision to put mechanical support, I think it is imperative to take the patient to the OR without delay. We always err on using cardiopulmonary bypass, and I'll go over that in my next slide. We err on placement of BiVAD support for these patients. These are our typical cannulation sites. Meticulous hemostasis is mandatory, but is often a joke. These patients are coagulopathic, and we believe that aggressive re-expiration for bleeding is imperative. So why cardiopulmonary bypass? Because many of these patients are at imminent risk of death, and putting them on cardiopulmonary bypass ensures immediate hemodynamic stability, allows time for the perfusionist and the anesthesiologist to correct the massive acid-base imbalances in these patients. And using cardiopulmonary bypass, you can safely transition to either L, RVAD, or BiVAD support. This is what the cannulation techniques look like. And the next slide shows you various sites of cannulation techniques, though for the RVAD, our preferred sites is the right atrial appendage and the outflow being the pulmonary artery. There's a lot of controversy on the inflow for the LVAD. Should it be the left atrium or the left ventricle? Each one has its pluses and minuses, but the outflow is always the ascending aorta. The intra-op management strategies, obviously the goal of the operation is to ensure hemodynamic stability, and we don't believe that leaving the OR unless you have good flows will be of any help at all. We use intra-op echo to optimize good cannular position and to make sure the ventricles are decompressed. Many of these patients are on massive doses of vasopressors, as these patients are extremely vasodilated. I spoke about intra-op hemostasis, and we often use factor 7A in these patients. Now, once you put mechanical temporary support, the strategies goes as follows. We either try to recover these patients, or we bridge them to a permanent LVAD if their heart doesn't recover, but their end organ function is reversed and recovered, including their brain, or as it is in about 1/3 of cases, they have neurological complications. We can withdraw support on these patients. Running over post-op management, we spoke about hemostasis and coagulation, which is a major problem in these patients. We often have to use an open chest in these patients. And many of the short-term devices need heparin, but clearly there is no point starting heparin until all bleeding issues are ceased. And many of these patients are auto-anticoagulated for 1 to 3 days because of the anticoagulants, or because of the anticoagulants that they have received in the cath lab or wherever. Infections, pretty standard. We give all these patients broad-spectrum antibiotics and change existing lines and catheters, and as we heard from earlier talks, be aggressive with nutritional support. Hypoxia, if they are in the OR, they are very hypoxic despite nitric oxide and Flolan. We add an oxygenator onto the RVAD device, which is pretty easy for the perfusionist to do. Pretty standard management of postoperative hypoxia if it occurs in the ICU. To summarize that post-op management, over the next several days, once they're in the ICU, pressors and inotropes can be weaned off. We adjust flows to keep a cardiac index between 2.2 to 2.4. We spoke about the oxygenator, we spoke about anticoagulation, antibiotics, nutritional support, and the most important thing is to have extensive discussions with the family and involve all members of the team, the surgeons, the cardiologists, the coordinators, because these families are in for a long haul with unknown outcomes. So it's important to have extensive and frequent family discussions with these patients. This was our algorithm that we published in the Journal of Thoracic Surgery a few years ago. It might be in your handouts, but once the patient comes in, the device that we use at our institution is the Centromag support. We then take them to the ICU. We spoke about the postoperative course. Around day 3, 4, 5, if the patient has woken up and their end organ dysfunction is resolving, we do an echo to look for recovery and then decide whether they can be explanted or, can they be bridged to a permanent device. Our experience at the University of Minnesota for about 66 patients over a 5-year period, and the one I'd like to highlight is the 42 bridge to decision with a slew of other indications. The mean support was about little over a week. With the Centromag device, we had no device malfunction, and 75% survived to a HeartMate, LVAD, or an explant, with the vast majority mortality being from neurological injury. Finally, on day 4, 5, 6, how does one assess weaning? There are obviously various questions. If you don't have permanent devices at your institution, when do you transfer these patients, where to and when? And finally, when to withdraw support. With most temporary devices, it's rather easy to assess weaning at the bedside. We can turn down the RPM for many of these devices, and even without an echo can look at basic things like mean arterial pressure, SVO2, cardiac index, CVP to assess both the left and the right side. Obviously, before you decide on an explant, an echo is mandatory to look at ventricular function and the evidence of valve regurgitation. And sometimes a slow wean over 1 to 2 days, gradually loading the right or the left ventricle may be beneficial to assess recovery. And if it's a reversible insult, such as the myocarditis or a post-cardiotomy state, it may be beneficial to wait between 1 to 2 weeks, even sometimes before explanting the patients. So clearly, I believe that for the acutely failing heart, even though the results and the success remain in the 40 to 60% range, I think there are many devices available now that can have effective and safe short-term support for these unstable patients in acute cardiogenic shock. And they are especially useful for those patients with uncertain neurological status with multi-organ dysfunction. 2 slides on the chronic. Again, this is well established, and the device that has been well established for the last 5 years is the HeartMate 2 device, with over 6,000 to 7,000 devices placed worldwide. I think this has become the gold standard for patients with chronic heart failure. Like all permanent devices, this one has an inflow into the left ventricle, a pump, an outflow to the aorta, and a driveline that usually exits out from the right upper quadrant. And as you can see, the 30-day survival for the patients in the current era is about 95%, which is almost, on par with many high-risk cardiac surgery, with the 1-year survival being 85%. The device, which is not yet approved but follows close on its heels, is the hardware device, with close to 1,000 devices being implanted worldwide. Again, the implantation techniques are fairly similar with this device, though it's a little smaller. And again, recent data from the American trials have shown, again, a very small 30-day mortality with a fairly adequate 1-year survival. So in conclusion, I think despite the encouraging results with the acutely failing heart, there's a lot of room for improvement. And I think there needs to be an aggressive strategy, not only involving the cardiac surgeons, but intensivists and other members of the team, to identify these patients as soon as possible to improve outcomes. And clearly, with newer percutaneous options available, the impetus is clearly on us to improve strategies for the patients with the acutely failing heart. Thank you.
Thank you, Dr.